Osteogenesis imperfecta transforms our understanding of how molecular defects create systemic disease. This brittle bone disease results from abnormalities in type 1 collagen, the protein that forms bone's structural foundation. Think of bone like reinforced concrete. The mineral provides hardness, while collagen fibers act as steel rebar, giving bones tensile strength and flexibility. Without proper collagen, bones become like concrete without reinforcement, hard but brittle, shattering under minimal stress. The mutations occur in collagen genes that encode chains forming the protein's triple helix structure. Even small changes can disrupt the entire structure. Some mutations reduce normal collagen production, while others create abnormal protein that actively weakens bone integrity. Most cases follow autosomal dominant inheritance. An affected parent has a 50% risk with each child. This happens because abnormal collagen disrupts even normal protein from the healthy gene, creating a dominant negative effect. 6 clinical types exist, reflecting different mutations and their varying impacts. Some reduce collagen quantity. Others produce structurally defective protein. This explains why some infants have multiple birth fractures while others don't fracture until walking. Understanding the molecular basis guides genetic counseling, explains why standard bone treatments fail here, and helps distinguish pathological fractures from trauma. Current research focuses on reducing abnormal collagen production rather than just managing fractures, moving from reactive care to addressing the fundamental defect. The clinical features of OI create a distinctive pattern that enables rapid diagnosis while raising critical questions about trauma. Blue sclerae stand as the hallmark feature. The abnormally thin sclera allows underlying dark pigment to show through, creating the blue tint. When collagen is deficient, the sclera becomes translucent. This finding is so specific that blue sclerae with fractures strongly suggests OI over other causes. Bone fragility defines the clinical impact. These aren't typical childhood fractures. They occur from normal handling, diaper changes, or even muscle contractions. The pattern shows multiple fractures in various healing stages, affecting long bones and ribs with minimal soft tissue injury. X-rays reveal thin, gracile bones that appear almost translucent. Facial features include triangular appearance from relative macrocephaly and narrow chin. Short stature reflects both growth plate effects and fracture complications. Severe neonatal forms present with dozens of birth fractures. Type 2 represents the lethal form, with fractures incompatible with life causing high stillbirth rates and early death from respiratory failure. The differential with non-accidental trauma creates pediatrics' most challenging situation. Both show multiple fractures in various stages. However, OI displays blue sclerae, bone thinning on X-rays, and typical fracture patterns, while trauma shows normal bone density and different fracture locations. This distinction carries enormous implications. Wrong diagnosis leads to family separation or endangered children. When uncertain, skeletal surveys, family history, and genetic testing help clarify the diagnosis. Understanding these features transforms OI from a symptom list into a coherent picture of collagen deficiency, enabling confident diagnosis while navigating the sensitive trauma differential. Potter sequence represents a fundamental concept distinguishing genetic syndromes from mechanical sequences. This distinction transforms our diagnostic approach, shifting focus from genetic causes to mechanical cascades. The critical difference lies in causation. Syndromes result from single genetic causes producing multiple anomalies. Sequences begin with one initiating event triggering secondary consequences. Think of falling dominoes. Severe oligohydramnios is the first domino, creating a predictable cascade of fetal abnormalities. Oligohydramnios drives all features of Potter sequence. Normal fetal development requires amniotic fluid circulation. The fetus swallows and inhales fluid while producing more through urination. When severe oligohydramnios occurs, this ecosystem collapses with predictable consequences. The primary causes all prevent normal fluid accumulation through different mechanisms. Bilateral renal agenesis means absent kidneys cannot produce urine, eliminating the major fluid source. Severe renal dysplasia creates non-functional kidneys with similar results. The key is bilateral. One functioning kidney maintains adequate fluid. Bladder outlet obstruction prevents urine from reaching the amniotic space, despite normal kidney function initially. Back pressure eventually damages kidneys through secondary effects. Prolonged membrane rupture represents external fluid loss, with timing proving critical for lung development. Understanding these mechanisms shapes counseling. Most cases occur sporadically, rather than following genetic patterns, contrasting with true syndromes where recurrence risks are predictable. The sequence concept guides management priorities. Since all features stem from Oligohydramnios rather than independent programming, treating fluid loss could theoretically prevent the cascade. This understanding drives therapeutic approaches, like experimental amnio infusions. The consequences of oligohydramnios create a predictable cascade, each mechanically linked to fluid absence. Understanding these connections helps anticipate complications and prioritize life-saving interventions. Pulmonary hypoplasia represents the most life-threatening consequence. Normal lung development requires space to expand and fluid to inhale. The fetus continuously inhales fluid, stretching developing alveoli and stimulating growth. Without fluid, lungs cannot expand properly. Additionally, the uterus compresses directly against the fetal chest, physically preventing expansion. The result is small, underdeveloped lungs, incapable of adequate grace exchange. Prader facies develops through direct compression. Without protective fluid cushioning, the uterus presses against the fetus, flattening the nose and displacing ears downward. Parents often describe babies as looking squished, accurately reflecting the mechanical forces involved. Growth restriction occurs through multiple mechanisms. Compressed fetuses cannot move normally, limiting skeletal growth. Decreased fluid swallowing reduces nutritional intake. These factors produce symmetrically growth-restricted infants. Limb deformities, particularly clubfoot, result from prolonged abnormal positioning. Without fluid allowing movement, fetuses become fixed in cramped positions. These are positional rather than structural abnormalities. Management focuses entirely on respiratory support because pulmonary hypoplasia determines survival. These infants require immediate intubation, with higher pressures than typical newborns. Critical warning: hypoplastic lungs under high pressure frequently develop pneumothorax. The combination of stiff lungs requiring high pressure and fragile tissue creates perfect conditions for air leaks. Prognosis depends entirely on pulmonary hypoplasia severity. Severe hypoplasia proves uniformly fatal, despite maximal support. Understanding this progression from oligohydramnios through compression to life-threatening lung problems helps teams prepare for aggressive management while maintaining realistic expectations. VACTERL Association represents a crucial concept in recognizing patterns of congenital anomalies. Its designation as an association rather than a syndrome reveals something important about developmental biology. The fundamental difference shapes everything from diagnosis to genetic counseling. Syndromes have single identifiable causes, producing predictable patterns. Associations describe anomalies occurring together, more frequently than chance predicts, yet without any common cause we can identify. This uncertainty impacts how we counsel families about recurrence risks and testing options. The non-random clustering provides insight into embryologic development. All VACTERL components arise during weeks 4 through 7 of gestation, when embryonic mesoderm differentiates into various organ systems. This timing suggests some unknown disruption during this critical window affects multiple developing systems simultaneously. Let's examine each component. Vertebral anomalies reflect disrupted spine development. Anal atresia occurs when structures fail to properly separate during gut formation. Cardiac defects typically involve chamber separation problems, VSDs and ASDs. Tracheoesophageal components often provide the first diagnostic clue. During week 4, the foregut divides into trachea and esophagus. When separation fails, various fistula configurations result. Finding a newborn with excessive drooling, choking with feeds, or inability to pass feeding tubes should trigger evaluation for other VACTERL components. Renal anomalies range from absent kidneys to connection problems, reflecting the complex development required for normal kidney formation. Limb anomalies specifically affect the radial side, thumbs and radius bones, developing during the same critical window. Understanding VACTERL as an association impacts clinical approach. Unlike syndromes where one feature predicts specific others, VACTERL requires systematic evaluation for all possible components. Finding esophageal atresia warrants renal ultrasound, echocardiogram, and vertebral assessment. But we cannot predict which additional features any individual patient might have. The clinical significance of VACTERL extends beyond pattern recognition. It shapes how we diagnose, manage, and counsel families facing this complex condition. The diagnostic requirement of 3 or more component features reflects careful research distinguishing true association from random occurrence. 2 anomalies might occur by chance, but 3 or more makes random occurrence vanishingly unlikely. This threshold ensures we're identifying true cases, rather than coincidental findings. The absence of specific diagnostic tests distinguishes VACTERL from most conditions. No genetic test or biomarker can confirm the diagnosis. This reflects our ignorance about causation. Without knowing what causes these anomalies to cluster, we cannot develop targeted testing. Instead, diagnosis requires systematic evaluation, followed by extensive testing to exclude known syndromes. Diagnosis by exclusion proves particularly important. Several genetic syndromes can produce multiple VACTERL components. Before diagnosing VACTERL association, we must exclude these syndromes through appropriate testing because they carry different prognoses and recurrence risks. The association with maternal diabetes provides one etiological clue. Infants of diabetic mothers show increased rates of VACTERL components, likely from hyperglycemia disrupting normal development during that critical window. This reinforces the importance of glucose control. Though most cases occur sporadically without identifiable risk factors, management requires coordinated multidisciplinary care. Each component needs specific intervention, with life-threatening issues taking precedence. Establishing feeding access, correcting cardiac defects, ensuring renal function. This staged approach requires careful coordination between subspecialties. Genetic counseling provides generally reassuring news. The sporadic nature means low recurrence risks, typically 1 to 2% for future pregnancies. However, counseling must include caveats about underlying syndromes and maternal diabetes optimization. Families often struggle with not knowing why this happened, requiring sensitive counseling that acknowledges frustration while emphasizing low recurrence risk and excellent long-term outcomes. The evolution of charge from association to syndrome represents a landmark achievement in medical genetics, demonstrating how advancing technology transforms our understanding of congenital anomaly patterns. For decades, clinicians recognized that certain anomalies clustered together more frequently than chance predicted, leading to the charge association designation. We could describe the pattern, but not explain it. Families faced having a named condition without understanding why it occurred or whether future children might be affected. The discovery that CHD7 gene mutations cause most cases revolutionized our understanding. CHD7 acts as a master regulator, controlling when and how other genes turn on during development. Think of CHD7 as a conductor orchestrating development. When the conductor falters, multiple systems develop abnormally, creating the diverse features we recognize as charge. Understanding each component through CHD7 dysfunction illuminates their connection. Coloboma results from failure of eye structures to close properly during development. Heart anomalies typically involve major vessel abnormalities. Choanal atresia blocks nasal passages, creating immediate neonatal emergencies when bilateral, since infants are obligate nasal breathers. Growth restriction and developmental delays reflect CHD7's broad role in cellular development. Genital anomalies affect the entire reproductive hormone axis. Ear abnormalities prove particularly distinctive, both external malformations and inner ear problems causing hearing loss and balance issues. The transformation to syndrome status carries profound implications. We can now offer definitive genetic testing through CHD7 sequencing, providing families concrete answers. The inheritance pattern typically involves new mutations, meaning unaffected parents face low recurrence risks, while affected individuals have 50% transmission risk. Understanding the genetic cause also guides research into targeted therapies. Rather than simply managing individual anomalies, researchers explore supporting the cellular processes disrupted by CHD7 dysfunction, potentially addressing multiple features simultaneously. Clinical recognition of charge relies on established criteria that distinguish this syndrome from other conditions with overlapping features. Understanding these criteria helps clinicians make accurate diagnoses and guide appropriate testing. The major criteria represent more specific features that strongly suggest charge. Coloboma creates characteristic keyhole-shaped defects in eye structures that are easily recognizable on examination. Choanal atresia, particularly when bilateral, causes immediate respiratory distress in newborns who cannot breathe through blocked nasal passages. Cranial nerve dysfunction proves particularly distinctive in charge. This includes facial nerve weakness, swallowing difficulties, and hearing problems that reflect the broad impact of CHD7 on nerve development. Characteristic ear abnormalities have become so recognizable that experienced clinicians often suspect charge based on ear appearance alone. The external shape combined with inner ear malformations, creating hearing and balance problems. The minor criteria include features seen in many conditions, but add supporting evidence when present with major criteria. Heart defects, growth deficiency, developmental delays, and genital hypoplasia all reflect CHD7's wide-ranging effects on development, but aren't specific enough to diagnose charge independently. Diagnosis typically requires meeting both major and minor criteria combinations, though the exact requirements have evolved as our understanding improved. The availability of CHD7 genetic testing has transformed diagnosis from purely clinical criteria to molecular confirmation. Genetic testing through CHD7 sequencing should be offered to patients meeting clinical criteria, providing definitive diagnosis and enabling accurate genetic counseling. This molecular confirmation helps families understand inheritance patterns and guides management decisions based on confirmed syndrome status rather than clinical suspicion alone. Prader-Willi syndrome represents one of the most fascinating examples of genomic imprinting in human disease, demonstrating how parent of origin for genetic material can be just as important as the genes themselves. This disorder transforms from life-threatening hypotonia in infancy to uncontrollable appetite in childhood. PWS is the most common genetic cause of life-threatening obesity in children, but this only captures part of its complexity. The disorder affects multiple systems throughout life, beginning with severe neonatal hypotonia, progressing through growth hormone deficiency, then manifesting as insatiable appetite typically between ages 2 to 8. Without strict environmental controls, affected individuals will literally eat themselves to death. The genomic imprinting designation requires explanation because it differs from typical inheritance patterns. The critical region lies on chromosome 15, containing genes that undergo imprinting, where certain genes are expressed only from one parent's chromosome while the other copy is silenced. For PWS, only the paternal copy should be active. The maternal copy is normally silenced. Everyone has just one working copy despite having 2 chromosomes. When that single active paternal copy is lost, PWS results. 3 mechanisms can eliminate paternal gene function. Paternal deletion affects 70% of cases, physically removing the region from father's chromosome. Since the maternal copy is silenced, no functional genes remain. Maternal uniparental disomy occurs in 25% of cases when a child inherits both chromosomes from mother and none from father. The genes exist, but both carry maternal silencing patterns. Picture having 2 locked safes when you need one unlocked. Imprinting defects affect 5% of cases. The father's chromosome is present but incorrectly silenced. This parent of origin effect revolutionized genetics, proving that inheriting the right genes isn't enough. They must come from the right parent with proper imprinting marks. The neonatal presentation creates a diagnostic paradox. Infants who will later develop life-threatening obesity initially present with severe hypotonia and feeding difficulties threatening survival. Recognizing these features enables timely diagnosis and dramatically improves outcomes. The severe hypotonia surpasses virtually any other condition, earning the description, "the most hypotonic baby you'll see." This isn't mild decreased tone, it's profound, persistent hypotonia affecting every muscle group. During examination, these infants feel like rag dolls, slipping through your hands with no resistance. The scarf sign shows elbows crossing far past midline. When pulled to sit, there's complete head lag with no attempt at head control. The weak cry often provides the first clue. Instead of robust crying, these babies produce feeble whimpers parents describe as kitten-like or absent entirely. This reflects hypotonia affecting respiratory muscles. They cannot generate forceful exhalation needed for normal crying. Poor reflexes compound the picture, with absent or decreased primitive reflexes that should be robust in newborns. Poor suck and swallow creates immediate management challenges. These infants cannot generate adequate suction for feeding, and when milk is delivered, they lack coordinated swallowing. Most require tube feeding for weeks to months. Criporchidism affects virtually all males, reflecting the same hypothalamic dysfunction that later causes incomplete puberty. Facial features create a recognizable pattern. Almond-shaped eyes result from epicanthal folds and narrow eye openings. The narrow forehead and small, downturned mouth with thin upper lip contribute to feeding difficulties. The key principle: severe feeding difficulties combined with profound hypotonia should immediately trigger PWS consideration. Recognizing this specific combination shortcuts diagnostic delays, enabling early intervention when it matters most. The inheritance pattern of PWS defies traditional genetics, creating counseling challenges that require understanding of genomic imprinting. Correctly identifying the mechanism directly impacts recurrence risk counseling for future pregnancies. Traditional inheritance assumes genes function equivalently, regardless of parent of origin. PWS shatters this assumption. Parental origin matters more than gene presence. Having the right genes from the wrong parent causes disease. Both chromosome copies are present, but the problem lies in which parent contributed the active copy. Recurrence risks vary dramatically based on mechanism, making precise diagnosis essential. Deletion cases carry less than 1% recurrence risk because these typically arise randomly during sperm formation. Maternal UPD cases face approximately 1 in 1,000 recurrence risk, slightly higher but still reassuringly low. Imprinting defects present the most complex scenarios, with some families facing up to 50% recurrence risk when caused by inherited imprinting center deletions. Management begins with methylation analysis, offering greater than 99% sensitivity for all three mechanisms. This examines methylation patterns that differ between maternal and paternal chromosomes. Abnormal patterns confirm PWS, but require additional testing to determine specific mechanism and accurate recurrence risks. Early diagnosis enables transformative interventions. Special feeding support during infancy includes high-calorie formulas and feeding therapy. Growth hormone therapy, started as early as 4 to 6 months, improves growth, body composition, and muscle tone. Early diagnosis allows families to prepare for appetite dysregulation, establishing controls before hyperphagia begins. The clinical pearl: early recognition leads to better outcomes. Children diagnosed in infancy who receive early interventions show significantly better outcomes than those diagnosed after hyperphagia onset. Early diagnosis literally changes their life trajectory, transforming a once fatal condition into a manageable disorder compatible with productive lives.